السلام عليكم ورحمة الله وبركاته. الله يعطيكم العافية والله يمسيكم بالخير جميعا. إن شاء الله today we're going to speak about the intervention for the visual efficiency skills and visual perception skills. We will give some information, and the most important part for you to when you understand the concept, how we assess the visual perception, how we assess the visual efficiency skills. Then from there you can do your intervention for the patient. I'm just looking to the okay, waiting area. Okay. So and briefly, what we spoke. Sorry. اوكي
انا ترى ما كنت مركز بنوع اعطاني هذا
استاذ نايف في عفوا في انستركشن معينه شيء معين استاذ نايف
وين خربت الدورة لحظة خربت الدورة.
طيب okay, we will start now. As we discuss regarding the visual efficiency skills, we're going to discuss regarding the intervention, but I'm just here having 4 people waiting in the waiting room. Okay, let me see how we can admit. Okay, one more. Okay, I think it's fine. Sorry. Now we are coming again. So we're going to speak about the visual efficiency skills. We need to know what's the intervention which we can do for the patient. And briefly, as we said before, visual efficiency skills meaning that the patient has the ability to move the eye smoothly. When they are moving their eye to right side, left side, up and down, through assessing the patient using the pursuit. When we are doing the pursuit assessment for the patient, we are making H letter, and we ask the patient to follow in all directions. So we ask the patient to follow on the right side, up and down, and then we're going left, and we are going up and down. And for me as examiner, I have to look to the patient eyes. So I should not be busy looking to the object which is moving. No, I should be looking to the patient eyes and ensuring that he is moving both eyes together. He's moving the eyes smoothly. And we need to ask the patient if the patient has any double vision. The other one for saccadic, when I ask the patient to look to 2 objects and I name the object, the color saying, okay, white, I'm expecting the patient to look to the white, yellow to the yellow. And also we do it for up and down also. And we look for the quality of the eye movement. If the patient moving the eye to the target, or if this patient, he is overshooting, he's moving the eye more or less. The other skill also we said about the fixation, if the patient is able to look to an object for 10 seconds, and we talk about the accommodation and also the eye teaming. So for the intervention, what can we do? There is something very simple. If you have a patient with a stroke or trauma or brain injury, and you would like to provide intervention for this patient, he just had the brain injury, train the patient to do the eye movement in all directions. Just forget about what's written here, visual memory, imagination, no, but just this is an example. This is called the exercise, which is the calisthenic exercise. In this calisthenic exercise, you are doing stretching for the eye muscles. We ask the patient, now I want you to look to the right side and just keep looking to the right side. Now I want you to look to the left side, going to the left side to the extreme left. Okay, now I would like you to look to the upper part. The patient will look up and he need to hold. Then I want you to look to the to down, and the patient need to hold. This is stretching exercise, can be done for the patient when they come to the session, and we ask them to do it 10 times for each direction. And when they go to the room, we ask them to do it also. When the patient is able to do this exercise also, we will go to tell the patient to look not only to right, left, up and down, also to diagonal. He will go to the angle, he will look to the right upper angle, okay? And we will add this movement as well. In addition to right, left, up and down, right upper angle and left upper angle, and also the lower angles as well. So we'll ask the patient now, I want you to look to right. The patient will look to the right side, and I want you to hold, or you can help him with moving your finger. I want you to look to left, hold, up, hold. You can try it now, and look down and hold. It's not really easy to be done. I want you to look in diagonal, down, and to the other side also as well, and up, and hold. This exercise, it's very simple, but it's good start for the patient to avoid for them having any adhesion in their eye muscles. So this is, you can start with it with your patient, even if they have a new brain injury or they're having the brain injury since a time. This exercise will help the patient to have better eye movement. And if the patient is a new brain injury, it will avoid that the patient will have any complication like muscle adhesion. The pursuit, we're doing the pursuit exercise using, you can use your finger, you can use for children a toy, or you can use a ball pen, and you will ask the patient to move from side to side. And you can here use the star. For example, you can draw a star for the patient and ask the patient to follow the star. So you will tell the patient, okay, I want you to follow my hand now. I will draw a star, and you're going to follow the movement of my finger. Sometimes it's tiring for you to do this exercise, but at least in the beginning, it's good to do it because we need to observe the eye movement of the patient. Also, for the cases who's having severe eye movement problem, it's preferred to do it with the right eye alone and with the left eye alone. So each eye to do alone for the pursuit, saccadic, and for the eye teaming. For this exercise, for these skills to do for each eye alone. So this is preferred. For also the eye movement, you can check in the YouTube. You can find a lot of eye movement exercise. It's like a ball or object moving in all direction in the screen, and you need to follow this object. But if you leave a patient who has brain injury in front of the screen, they will not concentrate and doing the exercise. So you need to keep an eye for the patient. I can also guide you for something very simple exercise. I seen it in one of the book. I tried myself, and it's also, I like it. This exercise, you will use a spoon in the exercise. So the spoon will be, the opposite side of the spoon will be facing the patient, and the patient need to look to his image. He will look to the image in the spoon, and he will move it by himself to all direction. If you can observe my eye now, I'm holding here the spoon, and I'm looking to the spoon. My image is there. It will be in all direction, because the patient can see their image in the surface of the spoon, they will be moving in all direction. So there is something, and we need to think about something very simple to be done for the patient in their home, because you cannot find machines with them. As rehab staff, occupational therapist, physical therapist, you can create some exercises from like sticky note, papers, from colors to let the patient to do these exercises. We should not think about something expensive for the patient to do. So you need to train the family how they can do this exercise at home. So for the pursuit, there is some simple exercise. You can use it with the patient. You can use the YouTube through some of the exercise for eye movement as well. This is one example of exercise. You can print this one on big like A3 or bigger paper, and the patient going to follow by themselves. Sorry, is the voice, is it clear now, or there is a problem with the voice? If you can write in the chat, please. If the voice is not clear, write number 2. If it's clear, write 1. Not clear, 2. So 1 is clear, 2 is not clear. Okay, please, if it's not clear, just write 2. This is the code. If it's not clear, I will know from the chat. So as you see, following the A, okay, following A until the end, this is eye tracking exercise. So you can think about your own exercises. This is another example of saccadic exercise. Saccadic, you can use toys, for example, for the children. And this toy is something that the child will prefer. And you will ask the patient, I want you to look to the yellow duck, the green duck, and you go for all direction. Always remember the star sign as you are drawing a star. This will help you to go in all direction. You can do saccadic, right, left. You can do it up and down. You can do it also in diagonal. Okay, I will check. I'm using only the chat here. Okay, please, if there is problem with the sound, just don't hesitate. Let me know. Okay, now this is another exercise which you can do for the patient. This is for saccadic as well. You can print this paper and put it on the wall. You will ask the patient to look to the to read for you the Y letter, and from the first row and from the last row as well. So from the first and last. First, this is L, 8, 4, V, P, S, E, P, A, D, and like this. By doing this exercise, this is part of the saccadic exercises as well. Okay. Also, there is, okay, good. It's the sound is clear. It's good. Also, there is a lot of books which is for eye movement exercise. You can use it. You can write, for example, eye efficiency exercises, and it will show you some exercise you can do for the patient. This one, for example, also that you are looking for the plus sign. The patient will be jumping for doing eye movement jumping between this object from this one plus to this one, to this one, to this one, to this one. So you will be doing jumping eye movement. So it's not necessary that you will have a high sophisticated machine, but you can do this exercise by yourself. Another one, you can have sticky notes. You know the one that we have for writing the note? You can have 10 or 15. You write number 1, 2, 3, 4 until 15, for example, and you post them on the wall. You will tell the patient, I want you to look to number 1, 3, 4, 6, and the patient will start jumping in the eye movement between the object. There is a book which is called The Brainwave. I don't know if you hear about it. Brainwave, this is a very good group of books. It is for the visual perception and eye movement exercises. You can have a lot of exercise in the brainwave as well. For the eye teaming, there is exercises can be done by the patient. Something very simple that we ask the patient to hold the ball pen and to move it closely to their eyes. They should move it from far to near, from far, and always when it comes, they will have more convergence of the eye movement. So the eye will be moving inside. Another exercise that the patient can do, they can hold the thumb of the left hand and the thumb also of the right hand. It will be like this. I'll show you. And patient will be looking to the near. You can try it now. You can look to the near, thumb, then to the far. Near, far, near, far. This is will make exercises also for the eye movement, for the eye teaming as well. So looking to the near, far, near, far. This is exercise for the eye movement, for the convergence. And by the way, if you do this exercise and you look to the near finger, you can concentrate now. Do it now, please. Concentrate to the near finger. You will see the other one, the far finger, you will see 2 fingers. So don't worry. This is normal double vision. If you look to the far finger, you will see the near one as double. This is normal. It's not an issue. This is physiological double vision, because when you are focusing your eye to the near object, it's natural that you will see the far one as 2 fingers, as double. This is also another exercise. Maybe the OTs, they are familiar with these beads when they give the patient to do some fine motor exercise. But what you will do this time, you will use a strain and you will put the beads there. This strain, the patient will hold the strain to the nose and it will be extended. So they will extend this strain, and the patient will start to move the beads near to the nose. So they will start to move it gradually to the nose, and this will be also eye teaming exercise. So imagine the strain here, it's here, and you are moving the beads toward the nose, and the patient need to focus and look to the to the beads. So it will be also eye teaming exercise as well. There is some patient, they are not improving. They're still having double vision. I will give you example for one patient. He is not able to ambulate and not able to use a cane, and we need to use for him electrical wheelchair. But we could not use the electrical wheelchair for this patient because this patient, he has double vision. So it was annoying for him. He's not able to ambulate even with the use of electrical wheelchair. We discussed the case with the assigned physical therapist, and we said, okay, now for this patient, when he would like to use the electrical wheelchair, we're going to do a patch. We will put a patch for one eye, and by that, the double vision disappeared. So when the patient would like to use the electrical wheelchair, he will wear a glasses, and this glasses, it is covering one of the eyes, and the patient, he don't have any double vision when he use the wheelchair and he use it safely. So for patching, it is not the responsibility of the occupational therapist to do it. It's mainly the optometrist who's assigning how many hours to cover the eye. But if you would like to do it during the exercise, like a patient who has double vision, and you would like him to do walking or to concentrate in the task that you are giving for him, you can use the patch only during the exercises. But if it will be used for medical purposes, and it will be used at the room, it should be decided from the optometrist. This is also type of batching. As you see here, there is a batch, but it is very small batch. It will not be clear on the glasses. So this patient, he's having the double vision when he look to this side. That's why there is a small batch here, and the patient will not have double vision. Another also way of dealing with the double vision is the prism. As you see here, the patient eye, it's moving internally. And this patient, when he looked to the letter A, it's showing two letter A, double A. As you see, this is A and A, because the eye is not straight. It's not in the proper position. After using a prism, this prism helps the patient to shift the letter A, and merge the two letters to be together. So this person, when he uses the prism, rather than seeing two persons in front of him, two objects, he will see one object. So this is one of the techniques that can be used to deal with the patient who has double vision. Depend, where is the double vision? Is it the object he see them beside each other, or he see the object over each other? So the prism therapy is one of the techniques which can be used for the patient. And actually, the eye specialist who's dealing with patient having eye movement problem, they can implement it and they can use it with the patient. The prism could be something temporary and could be something permanent as well. Okay, this is one of the games that I like to introduce it for the colleagues. It's called the multi-matrix game. And this multi-matrix game, they assume that it is used for a lot of things. Like this is the one that I have. For spatial awareness, pattern recognition, memory development, reading skills, motor control, vestibular system, eye movement control, eye teaming, peripheral vision, visual discrimination, and visual tracking. It is a very nice game that you can use it with your patient. It will give you at least every day 30-minute exercise for the patient for vision, and the patient will not feel bored because it's a lot of exercise. It's not only searching, it includes part for the visual discrimination, and part also for figure ground as well. And also there is part for visual closure. So I will not explain how to use it. Please search in the YouTube, right? Multi-matrix game, and you can see the benefit of this game and how you can implement it with your patient. It is something, I think 350 riyal, something like that, but it's really valuable with the patient, and it has multiple use. Also, maybe I will check if I have the card for the website, so you can visit the website and see how it can be used. But you can search in the YouTube as well. For visual perception, this is for the direction. If patient has problem with direction, there is books also for visual perception training. You will have a lot of exercise for the patient. This is example for the direction. The patient will identify the direction of the arrows, up, right, left, and also will identify also the direction of the line, like this additional line. Where is it? Is it in the middle, up, middle, down? Is it on the right or the left? Also, another way you can do it by yourself, writing words or letters. It is not in the correct manner. Okay, it's vice in the vice way that you write it flipped, and you will ask the patient to tell you which letter it is not written in the proper order. So this is some example for the spatial relation. Also, there is something that we can do for the children, for pediatric. They can use a car, they can play with a car, and you will tell them now, I want you to go right, I want you to go left, or I will use the car in front of the child and a small toy of car, and we tell him, okay, direct me now, where to go, right, left. So this will be an enjoyable exercise for the patient, especially for the pediatric. This is some of the books, which is I would recommend not only this box, but any box can be used for visual perception, but this will save a lot of your time and effort. Like visual perception skills, this is a PDF book, and any other books also for the visual perception. You will have some exercise for the spatial relation, visual closure, for a lot of tasks. You will find it in these books. So I advise you to search in the application what application can help you to do these exercises for the patient. Look in the YouTube and look also in the books, which can be providing a lot of option for the patient. Visual analysis skills, there is a lot of exercise on visual memory, for example, on visual discrimination, on constancy. I put also for you in the resources some of the application that you can use for vision. It will be shared with you today within the Google Drive file. So you can have some application, but this is not the only application. There is a lot of application can be used for the patient to improve these skills. The starting point is to know what is the problem with the patient. Is it eye movement? Is it visual perception? And from there, you can use your creativity and you can do a lot for the patient. This is also some application as well. We used it with some of the patient, with children, for the patient to find what's the mistake. This is depend on visual analysis, and the patient will tell you the mistake as well. There is one application also, which is the tracking and perceptual skills designed for occupational therapists. I could have the trial copy of this one, not the demo copy. Also, you can download this one on your PC and you can use it with a patient. There is a lot of exercises, as you see here, and you can control the difficulty of the exercise as well. So there is a lot of option, but you need just to search and look for the option which fit for your patient. For visual motor integration, you can create exercises for the patient, or you can look for resources or books for the visual motor integration. If you have a plan to work on visual rehabilitation, it's worthy to have a book on visual motor integration to help you on the exercises, another book for visual perception exercises as well, and for the eye movement exercise. This will be a great resource for you, because if you assist the patient using motor free visual perception test or the VMI, you cannot use it as intervention. You can use it only for assessment. You need additional resources as intervention, and there is a lot of resources for the intervention. If in your facility you have advanced technology, like this machine, for example, this is Tyromotion. Some of the machine with virtual reality features, it allow you to control the amount of difficulty for the exercise, the stimulus, from where you want the stimulus. You need it from right or from left side. Where is the difficulty you need it for the exercise? Like, for example, for this patient, we can make the number of, this is apples falling, and he needs to ensure to put it in the basket, and the patient is using his finger for the exercise. And we can control the amount of stimulus in the left side. If the patient has visual problem on the left side, we will make more stimulus on the left side. Or we can increase the speed of the exercise, so the patient will have more eye movement. So if you don't have equipment, you can do it. If you have equipment, you can also utilize them. The virtual reality glasses can help as well. And as we said, the applications, there's a lot of applications. Look for this application and utilize them. Many of these applications, it's made for the games, but you can utilize it for treating the patient for the visual efficiency skills and visual perception skills as well. You can use it in a therapeutic way. This is regarding the visual efficiency and visual perception skills. And now we'll be speaking about a very important condition which is happening for the patient with brain injury, which is the visual field and visual neglect. So we'll talk now about the visual field, how we do assessment and how we do intervention for the patient who has visual field. Actually, the first encounter for me in visual rehabilitation was working with patient with visual field defect. That patient, he was having complete blindness on the left side. He cannot see the left side at all. And when I started to search on some article, how can we help the patient and how can we support him? And I proposed for him some exercise. He was losing the hope. He said, I will not improve. You don't try with me. And I will show you within the slide, this patient, what kind of improvement that he has. So the visual field in simple word, it is the field of view for the external world. If I am sitting now and I have my computer and my PC in front of me, everything I'm seeing surrounding me in the room, this is my visual field. But my eyes should be fixed and my head should be fixed. I cannot say that I can assess visual field for the patient if the patient moving the head to the right and left, or moving the eyes up and down or to all direction. In visual field, it's the field of view. You can see while the head it's fixed and the eye is fixed as well. Intact visual field depend on the distribution and integrity of the retinal receptor. The visual field, it depends that our eye is not affected. There is nothing is closing the lens from the light from going to the lens. For example, the patient who has cataract, which is called in Arabic المي البيضاء, it will be closing the light from going to inside the eye. The lens will be having this white matter and the light will not go inside. This is a problem for visual field. Another problem might be that the receptor, the eye receptor, which is the cones and rods, it's damaged. This will cause another problem for visual field. Another problem, which we will talk about it now, if the patient having a damage in the brain in the vision area, in the occipital loop, and this patient who has damage in the occipital loop, they will not be able to see part of the vision. This is example. There is some patient might be able to see the word like this, or patient might be able to see the whole picture, but he cannot see one of the quarters, or a patient cannot see in the middle, or could be patient cannot see on the side. Causes for visual field could be because of the retina problem, glaucoma, which we will talk about it, cataract, and neurological disorder. We will talk here about the neurological disorder. As we talked before in the first day, in the part for the physiology of the visual system, our right side of the brain is responsible to see on the left side. And I would like to look here that this is my right eye, and the right side of the right eye is responsible to see on the left side. Right side of the left eye is responsible to see on the left side. So both eyes, right and left, responsible to see where? Left. And look to the blue color now. The left side of the left eye is responsible to see right. Left side of the right eye responsible to see right as well. All the vision and the picture, the blue picture here, the blue here, it will go to the left side of the brain. And the red one will go to the right side of the brain. So right side of the brain responsible to see left. Left side of the brain responsible to see right. This is the visual field, which is for normal people. It's 160 degree because of the nose. You cannot see more. So if you close your one of your eyes, you will see until here only. So 60 degree, and you will see until 100 degrees. So this is 160 for each eye. This is for the horizontal. For the vertical, we have 60 degree up and 75 degree down. So 135 degree. In total, we have for both eye 180 vision, and from the vertical 135 degree of the vision. Now, if a patient having a damage in the right side of the brain, patient having damage in the optic radiation, or maybe in the occipital lobe, this patient will lose the ability to see on the opposite side. So this patient, he has damage on this side, he's not able to see the left side. Type of visual field defects. This is the picture for Paris with the left eye, and this is the picture in the right eye. What the brain will do, the brain will merge the picture together. But now, with patient who has left Heteronormas Hemianopsia, which is patient cannot see the left side, look now for what he can see in his right eye. He can see only this part, this picture. And with the left eye, he can see only this picture. So the missing part is the left. This is called left Heteronormas Hemianopsia. Why they call it homonomous? Because it is equal. Patient cannot see left side in the right eye. He cannot see left side with the left eye. So it's homonomous. The same amount that he cannot see in both eye. Imagine for those patients who has the visual field defect, they cannot see this area. They can see part of the vision in the right eye. Then the picture will come, picture will disappear, then it will come and will disappear. That's why there is some patient of the patient who has visual field, they might tell you that I see strange things. There's something coming inside. I see something, then it will disappear and it will come again and it will disappear again. So it might be like some of them, they will think this is like hallucination. This is called altitudinal hemianopsia, which could happen in the superior part. The patient cannot see the whole superior part when their eyes is fixed to you. They cannot see upper or they cannot see lower. And we said the patient who cannot see upper, what is the lesion? The patient who cannot see the upper part of the visual field. Do you remember where is the lesion? Is it in the parietal or temporal lobe? Patient who cannot see upper. What do you think? Okay, upper is temporal and lower is a parietal. Okay, so upper, remember, patient cannot see up, this is temporal. Patient who cannot see down, this is parietal. So this is called altitudinal hemianopsia. And this is not homonomous hemianopsia. This is another part which is called, as you see here, the heteronormous hemianopsia. That one homonomous, it is equal, it's the same direction, but this is opposite direction. Patient cannot see in the middle for both eye, or patient cannot see in the outside for both eyes. This is called heteronormous hemianopsia. And this is this example of a patient who can see only in the edges. They can see right, they can see left, they can see up and down. This is something called tunnel vision. The patient is looking in a tunnel, like he's looking in a tube. So those patients, when you do assessment for the visual field, they will not be able to see in the middle, but they can see they can see on the side. Sorry, to correct, this is called the tunnel vision. Patient can see only in the middle, but this one patient see only on the side. They see on the side. This one patient don't see on the side, but they see on the middle. This is called the tunnel vision. And this is called the quadratopia. The patient, they are not able to see only one quarter. It could be the right upper quarter or the right lower quarter, or it could be in the left side. When you do assessment for the patient, we will come for the visual field assessment. You will find the patient is not able to see the quarter. And this is if the patient has the problem in the occipital lobe, they might have scotoma, that the patient eye is good, optic nerve is good, but the patient cannot see because of the injury in the brain. There is darkness. This is called central scotoma. Okay. This picture will illustrate for you the type of visual field defects. This one, number one, if the patient has the problem in the optic nerve, there is damage to the optic nerve, patient has blindness in one eye. If the patient has the damage in the optic chiasm, number two, patient having hemianopsia, but he is able to see only in the middle. He's not able to see in the part, which is we said this is called tunnel vision. A patient see only in the middle. This is example number 7 for left hemianopsia. Patient cannot see the whole left side if the damage happened in the occipital loop. What if the patient has the damage in the this one? There is a quadratopia, but it is in the upper part. This is in the temporal loop. So this is in the temporal loop, and this is in the parietal loop. If he has cut, this is number 5, in the parietal loop, he will have this type of hemianopsia, of the quadratopia, sorry. And if the patient has the lesion in the temporal loop, they will have this type of the quadratopia. You can save this picture, and it will help you to understand if patient having a problem with visual field, it will give you more understanding for the problem. The prevalence for visual field, like the study is saying 20 to 30% of patients admitted to your facility with neurological disorder, they are having visual field problem. It's not related only to brain injury, but it's related as well to not traumatic brain injury only, stroke, cerebral palsy, patient who's having multiple sclerosis, they will have also problem with visual field, and patient who's having surgery because of cancer, they might have visual field defect as well. The percentage for stroke patient who's having visual field, it is like from 8 to 25%, and it's more common if the patient having right stroke. If the patient has right stroke, it's more common to have the visual field problem. How we assess the patient? There's many ways of assessment, but I will focus mainly on the confrontation test. There is some of the assessment which used by optometry, but I will just give you idea about it. First of all, the history. The family will come to you and will tell you, you know, my father was good or my brother was good until the stroke or the traumatic brain injury. He is not able to see with the right eye, or the patient is not able to see with the left eye. So if you hear that patient after brain injury not able to see in right eye or left eye, you need to think immediately about visual field defect, because the family, they think if the patient is not able to see the left side, that he has blindness in the left eye, which is not right. As we discussed before a while, we said both eye responsible to see left, both eye responsible to see right. So if you hear that, you need to think about the visual field problem. So the observation and the family input is very important. When you read the report, you find this patient has injury in the parietal loop. You might think about quadratopia in the lower part, or patient has the injury mainly affecting the temporal lobe. It will affect the upper, and for the parietal, it will affect the lower. Patient has it in the occipital loop. Okay, could be central scotoma or could be right or left hemianopsia. Some patients, they are having the occlusion and having the stroke affecting both occipital lobes. So this patient might have complete cortical blindness, which is, as we said, can be assessed, and some of the cases can improve as well. There is a way for assessment, confrontational test, and other technique. It's for the optometrist, but just to give you an idea. Regarding the confrontational test, you need to sit in front of the patient, and you need to sit at the level of the patient. Even this way is not really true. You should be at the same height with the patient. If it's pediatric or adult, you should sit at the same level. And you're going to examine if the patient can see your fingers, your hand in all directions. I will show you part of a video, which is we showed yesterday. Okay, let me share the screen. Okay, let me go from the beginning.
Eyes. Allow you to point at the finger you see moving.
Okay, before we go to the visual field assessment,
specific tests of your vision. You can just keep
this is, they call it visual inattention, but I have comment on this assessment. I'll share with you the comment. Now, observe, this examiner will do the assessment for the patient, and they said this is visual inattention. Actually, this is not visual inattention test. When he moves both of the fingers together, okay, this is called something, it's called extinction. The patient, some of the patient with visual neglect will not realize that both fingers is moving together. So we'll be sharing with you this video, but I will give you the proper technique on the visual inattention or visual neglect assessment. So disregard this way of assessment for visual inattention. The most important for me here to show you the visual field assessment. Here.
If you just cover one eye with the palm of that hand for me, I'm going to cover the other.
You can do it with each eye alone, and you can do it with both. But it's better to do it with covering each eye alone. Now, he covered his eye.
Keep looking into my open eye. Yes.
Now, what I want you to know, this is my visual field. This is my visual field, and I should divide it to 4 areas. From here, okay, I will cut the area here, and from the middle, I will cut it here. So I will have how many quarter? 1 quarter here, and 1 quarter here, and quarter, right lower quarter, left lower quarter, and right upper quarter, and left upper quarter. So you will divide the vision from your eyes to right and left, and up and down. So you will end up with 4 quarters. You need to do stimulus for the patient in each quarter. The distance from me to the patient should not be more than 1 meter. I should be close to the patient. See how is the way they are sitting, and my head should be at the same level of the patient. You see, both of their head at the same level. If it's a child, move him up. If it's somebody who's very tall, use a bigger chair to evaluate the patient. Now, something very important, when you do assessment for patient with brain injury, don't be very quick in the assessment. For example, I will do, okay, can you see my finger? Can you see my finger? Can you see my finger? They will not see anything. So what you need to do, you need to do the assessment slowly, give them the instruction slowly as well. So you will tell the patient, okay, now I'll be doing for you a visual field assessment, and I'll be moving my finger or my hand. I might not move it. Maybe I'll move it, or maybe I will not move it. If you see my finger is moving, just tell me it's moving. Now, remember, if you're doing the assessment for patient with stroke or brain injury, they might have a problem with right and left. Don't tell me which one is moving, right or left, because they will be confused. The patient is sitting in front of me. Maybe he will tell you right, meaning his right hand, or your right hand, or they will be confused. So tell him, if you see my finger moving, point to the finger. Only just point to the finger. Say, point, is it this one, this hand, or this hand? Only. This is very simple. So I will move my finger. Is it moving? I'll go. This is the first quarter. The deadline, the guideline here, that you are sitting in front of the patient, your eyes within the level of his eyes, and your hand should not be very close to the patient, should not be very close to you. Where the hand should be? Is it should be near to the patient? No. To me, no. It should be at the middle. What's the rationale about this assessment? That if you put your hand, your finger in the middle, this area in the middle, it is a guideline for you. Whatever you can see, the patient can see. So I will move my hand for visual field assessment within the area that I can see it. And my hand should be in the middle. If the distance between me and the patient is 1 meter, my fingers should do the assessment at 50 centimeters, at the middle of the distance between my eyes and the patient eyes. I hope this is clear for you. Is it clear until now what we discussed? If it's not clear, please let me know it's not clear. Now, look, now he will assess each quarter. What he do for the patient, he cover the eye, and assuming what he can see in his eye, the patient will see the same in his eye as well, and he do stimulus in this area. You can move your finger higher or more to the left. If you still see your finger, the patient is able to see it as well. So do it at the middle. This is the guideline for you to do in the middle. Now he will do it in the lower part.
Yes. Yes.
Okay. And also when he, the examiner, what he did, for example, he was doing the assessment for the patient, and he went to assess the other area. He did not move his finger like this and tell him you can see or no. No, what he did, he exchanged the hand and used his other hand. Because some patient, when they see your hand moving, they will tell you, okay, yes, there is movement. So what you should do, you should do it in a smart way. If you're going to examine the other direction, you're going to cover with the other eye. Let's just repeat this one again. Now he examined the left. He will go to the right. He just exchanged the hand, so he will not give hint for the patient. The patient with hemianopsia, if this patient has hemianopsia, he will not be able to see all the stimulus on the left eye, but he can see them in the middle, and the right side he can see them.
Eye for me.
Also for the opposite eye, it could be very easy for you not to cover. Okay, خلاص, with only one, with both eyes together. Okay, we'll tell the patient, now I want you to look to my face and don't look right or left, and I'm going to move my finger. If I move it, just let me know it's moved. It's moved. Yes or no. I am not able to do more because of the camera, but you need to do more. Since you can see your fingers, do it, no problem. But I cannot tell the patient, for example, my hand is I cannot see my hand, and I tell him, my hand is moving. No, it should be in the middle, and I can see my hand, and I assume the patient can see the hand. Just remember to do it slowly. Don't do it very fast with the patient, because they are having a brain injury, and they will have like a problem in the processing.
Yes. Brilliant.
Okay. Regarding the assessment of the visual field, any question for the assessment for visual field? Please, if you would like me to repeat it again, I don't mind to repeat it as many times, but we need you to get the concept and to get benefit from the training. So please, any question? Okay, so this is for visual field. You might assess a patient who has visual neglect, visual inattention, using the confrontation test, and the patient will tell you, yes, I can see, I can see, I can see, I can see. So this is purely visual field assessment. It will tell you if the patient has blindness on the left side or on the right side or in this quarter or this quarter. So this is not, it's not an assessment for visual neglect. Visual neglect is a different story, but this is visual field. Will tell you where is the problem. Okay, question. What if my patient, I tell him, okay, I want you to look to me, and this patient is cooperative. He looked to me, focus in my eyes, and I do the assessment. What if I have patient, I tell him, look to me, and he keep looking around. Patient has cognitive problem, keep moving the eyes. What I should do? It will be very difficult to do this assessment for this type of patient. So what you need to do, you need to do the confrontation assessment, but in another way. You will have one of your friends to sit in front of you, and I will tell my friend, sit in front of the patient. Okay, I am the patient, and somebody is holding this for me, and let me use this. My friend or the therapist with me will hold the ball pen, and I am the patient. He will ask me, okay, I want you to look to the ball pen. Only look to the ball pen. I will look there, and your colleague who's sitting in front of the patient will be observing the patient if he's moving around or no. Just he will keep reminding the patient. Okay, I am the patient, and he's reminding me. Look to the ball pen. Okay, and I keep looking. Look to the ball pen. I keep looking. You will do the assessment for the patient, but from behind. You will come from behind and move the ball or move a toy to the patient visual field. Now, if you observe this patient, he look to the stimulus which come from behind. It means that his visual field is good. So again, your colleague will sit in front of me. He is the therapist, and I am a patient, and he will hold this ball pen for me. For a children, it could be a toy, something they like it. We'll put it in front of them. And you as a therapist will come behind the patient, and you will use stimulus. And when the patient see the ball, they will just look. So your colleague will tell you, yes, now he looked to the stimulus. Again, he will come with a stimulus from the other side, and you will observe the patient is looking to the stimulus. So what you will do, you will assess again the 4 quarters, quarter number 1, quarter number 2, quarter number 3, and number 4. So 4 quarters. Every time you will come from behind the patient, and you will use the stimulus to the patient, and your colleague who's sitting in front of the patient will tell you, is he looking or no? So this is another way of doing the assessment for the patient. Another assessment, which will not explain about them, but just to give you idea, the Amsler grid assessment. It's used for patient who's having problem with the macula, and to assess how much the worsening in the eye itself, how much the eye it's having the disease, and how much the disease is progressing. The TANGNet screen test, also it's like a stimulus going to the screen, and the therapist will mark there how much the patient see. For example, for today, he could see at this degree for comparing to previous week. So it will give a way of comparison, but this is not for you. It's only for used by optometrists. It's just to give you an idea. The Goldmann perimetry test, the patient head will be here, and the patient will be looking at the center, and the therapist will be using a stimulus, or the optometrist will be using a stimulus inside this plate. And when the patient see the stimulus, they will mark the area where the patient has seen the stimulus. And now there is a new assessment which is used in the visual field assessment called the kinetic perimetry. This is the concept. It's an object moving, and when the patient see the object, they will just click on the button. So when the patient see the stimulus, they will click, and it will end up by giving you an idea how much the patient can see, and you can use it to compare. It will not be done by the therapist, but you can tell the patient that you need to do objective visual assessment. This is called the automated perimetry test. It is one of the assessments which is used for the patient, but it has some limitation. This assessment, it is a light, it's a very dim light, which will come and it will disappear immediately. So if the patient see the light, the patient will click. Here you can see a button, the patient will click. It will assess only 30 degrees of the vision. But this assessment, it's good for the patient who has eye problem. They have very good attention. But for our patient who has brain injury, it's not really recommended. Because what will happen? The patient will not have the ability to press when they see the light. The light is very quick and it disappears quickly. So the patient with slow processing, it will show that those patients, they are having a visual field problem, while they are not having that, but they are having slow processing. So this is not really recommended for the patient with a stroke. And even when the patient go to the optometrist, they struggle to do the assessment. But the good thing about this assessment, it will give you an idea. For this patient, for example, he is not able to see the left side, which is he has left hemianopsia. If the patient has full cognitive ability, yes, it's good. Patient with slow processing, it will be difficult for the patient. Okay, what we need to know about the visual field defect post the brain injury. I don't know if the screen is clear for you, or it's because here it's not showing. There is something dark on the screen for you also. Okay, let me share it again. There is a technical problem. Bismillah. So there is a thought that the patient has. Okay, so there is a thought that the visual field is affecting the patient independent. but actually it's not true. Patient with visual field problem, they might come to your unit, they might be admitted, and at discharge date, they will tell you, you know, I am having problem with my visual field. I cannot see right side or left side. If this problem combined with cognitive, like with patient who has visual neglect, yes, it can affect the patient independent and can affect their activity of daily living. But the patient with only visual field, most of the time they are having good independent in their activity of daily living. But there is mixing between the visual field problem and visual neglect. People, they think it's the same, while actually it is not the same. There is big difference between them. But patient with visual field problem, they might have also visual neglect. They might have both of them together. That's why you need to do assessment for visual field and visual neglect. If patient has visual field, it might affect their reading, their ability to drive, and some of their functional abilities. It affects the driving, as we said. Patient might have safety problem when they are having the visual field problem. It might affect the activity of daily living if it's combined with other problem like the visual neglect. Now, people will say, okay, this patient, and unfortunately, sometimes some optometrists, they will say, okay, the patient will improve with time. He has a brain injury, no problem, patient will improve with time. But actually, this is not true. Patient, they will gain some recovery because of the neuroplasticity, but it will not be the full recovery that we are looking for. If you would like to have full recovery for the patient or the maximum recovery, you need to do exercises and you need to support your patient through implementing intervention. So the spontaneous behavior adaptation, that this patient we will say, okay, this patient has visual neglect, khalas, he will train himself to look to the affected side. This is not enough. Additional exercises need to be done for the patient. There is 4 intervention, which is very famous in dealing with patient who has a visual field problem. One of them is the optical assistance, such as using a prism. That patient who has left hemianopsia, they have blindness, cortical blindness on the left side. They cannot see the left side. You can help them using prisms to be able to see some of the vision on the left side. The other one, the restorative training technique. Third one is stimulation of detection capacities. And the 4th one is the visual search training. We will come for them one by one. Okay, look to this picture. This patient, because he has right hemianopsia, he could not see the stop sign. This is the original view, the original picture. Okay? This patient, he has hemianopsia. He cannot see right. Then what happened? Part of the picture disappeared. Okay. There is some type of prism which can be used with the patient, like this type of prism. It is a prism which is for the whole half of the glasses. It will be for the whole half of the glasses. This is not really recommended for the patient. Why? Because if the patient look at the edge of the prism, they will look at the edge of the prism. Okay, they will be able to see the stop sign, but they will not be able to see part of the picture. If you see here, using this type of prism, the child disappeared. The child is not there anymore. So not all type of prism is recommended. If you see somebody is using the type of prism that it's covering the whole half of the eye lenses, it is not recommended. Let me show you example. For the shape of this prism, it's only like example. This is the shape of the prism. Okay, if we come a patient that he need a prism and we put it for him We put the prism for him at the middle of the glasses. What will happen for this patient? If this patient look at the edge of the prism, he will lose part of the picture. He will not be able to see. Okay, yes, if he look to the prism, it will make shift for the object. But if he look at the edge in this area, he will lose part of the vision, because this prism it is using the central vision. It's using the macula, central vision. But there is another type of prism which is called the Ilibili Prism. If you can observe here, the prism for the patient is not depending on the central vision. This is depend only on the peripheral vision. So what happened? The patient can see only this part of the picture. So it will help him to see part of the vision, part of the peripheral vision, and he will know that there is something. There is a stop sign. If the patient used this type of prism, it will make him lost part of the picture, and it will not be safe for the patient. But this is now the advanced prism which is used for the patient with hemianopsia. It is helping you to see central vision, no double vision, but you will see part of the picture on the right upper side and left lower side as well. Type a question: what if the patient has a quadratopia? He has a quarter, he cannot see the upper quarter. Do I still need to put for him 2 prism or 1 prism? What do you think? Patient who has quadratopia, he cannot see the upper quarter. How many prism he need? 1 or 2? Okay. So he need 1. It's not necessary to put 2 prism for the patient. Like for example, this glasses. This is this type of prism. It's called the press-on prism. This is the prism. Something. Okay, let me check if it's. It is something that it will make if you can observe now in the picture that it make my face. We have like double vision. So let me try just to show you how it can shift the picture. See. So what happened? It will pull the picture. It will pull my picture. So this is the function of the prism, that it will help the patient to pull the picture. And this prism, it will function only until 20 degrees. But if the patient put the fixed prism, it will help the patient to pull the picture 40 degrees. And for example, patient has hemianopsia, he can see until here. He cannot see left. With using the prism, he can see another 40 degrees, which is functional for the patient. From my experience with our patient, they don't really prefer using the prisms. But we find like some patients, especially the young patient, they really like to use it, and because it helps them a lot in mobility. Many of the patients, they don't prefer to use them because of they don't want others to see that they are having a problem in their vision. So this is the prism therapy, and this is the patient. He cannot see left side, and here the patient can see part of the left vision. The restorative approach, it depends on the exercises that given for the patient to improve their visual field. And actually, there is low evidence in this theory, and the patient who is not improving like within the first 2 or 3 months of visual field might not increase the degree of the visual field. There's some like machines, they will tell you use this machine and it will improve your visual field more. Actually, still the result on these researches, it is limited. There is low evidence on this intervention. So it depends on the increase of the visual field itself. But I would like to tell you that if a patient has a stroke, still they have ability to improve their visual field within the first month, or maybe within the second month, they can improve their visual field. So we will not tell the patient, okay, you have brain injury since 1 week, خلاص, you will not be able to see. No. We tell him within the first 2 or 3 months, your visual field will be stable, and then we can do also more exercises to improve your visual field. Something interesting I would like you to know is the blind sight. Those patients with complete hemianopsia, they cannot see left side or right side. Some of them, they have some abilities for vision, but they don't know about them, which called a blind sight. Those patients, if you move your hand in the blind area, they will tell you, I cannot see anything, but I feel there is something moving. I feel there is something moving. So some of them, they can tell you, I cannot see on the left side. I have hemianopsia. This is only for the patient who has brain injury. But I feel there is somebody sitting beside me. Actually, this is not a feeling. It is ability, but the patient, they don't know the ability. Let's remember, we said in the vision, patient will see in their eyes, picture will go to the optic nerve and will go to the occipital loop. Now, the eye has no problem. Optic nerve has no problem. If the picture will go to the occipital loop and the patient has some neuroplasticity, the patient will know that there is object in front of me. They will realize that there is a stimulus, but they don't know what is it. Your role as a therapist to check if your patient who has hemianopsia has this ability or no. What you can do using some stimulus on the affected side. I will sit on the affected side of the patient, and I will use like lights. I will use big object with high contrast. For example, if the table should be white table and I use black object, or the table will be with high contrast with the objects. This patient, when I started with him the exercises for the blind side stimulation, he told me, please don't joke with me. I cannot see. I told him, okay, let's try. We tried by saying, okay, now I will just move my hand. Tell me, is it moving? There is movement or no? Yes or no? Then he realized that he has ability to identify if my hand is moving in the area that he has cortical blindness. After that, we started with big object, like the bag here. You see a black bag with a table with high contrast. And I told him, is there a bag on the table? Yes or no? Yes. Then he was able to build the confidence that I can do it. Yes, I can do it. Then I put for him after 5 weeks. I put for him 10 objects. I put for him 10 objects, and I told him, okay, identify these objects in the intact visual field. Okay, this is a bag, this is a cone, this is a plate. Then I started putting this object in the blind area. Let's say he cannot see on the left. As you see here, he cannot see on the left. I start to put them one by one in the blind area. This patient was able to identify 8 out of 10 objects. So 80% of the object was identified by this patient while he's looking straight. So the patient is looking straight, and I was putting the object on the blind area, and the patient was able to identify 8 objects. This is not the first and last patient. Sorry, this is not the last patient for the blind side stimulation I have seen. There is another 3 patients that I treated, and they had very good improvement for the blind side stimulation. One of the patients, one of his main problem was the visual field, and it was embarrassing for him because he is a young man, and he told me, you know, whenever I go to the malls, I start hitting the people while walking. And it is really embarrassing when I am, I am a young man and I'm hitting a lady. They will think that I am a bad person, and I have a lot of trouble because of that. So that patient, we do for him stimulation exercises using light in the affected area, using object, using color, and that patient was able to improve part of the visual ability. So cortical blindness is different from the blindness which come from the eye. From the eye, you cannot do much. You need to do compensation. But if it's from the brain, remember, there is a possibility for neuroplasticity. If there's a neuroplasticity, patient will gain some of the vision. We defined in the yesterday the cortical visual impairment, the CVI. It is those patients who has visual problem, but they have some residual vision. The compensatory approach, you train the patient to compensate. Okay, when you walk, you need to search on the affected area. The patient, they need to use their intact vision. Patient who has, he cannot see left side and they only can see right. So what they will do, they need to move the head and move the eyes to the affected area. So always they need to move the head and the eye. Okay, we'll have the break after 5 minutes. Okay, the client will move his eyes and head to search using the non-affected vision. Client with left hemianopsia will move his head and eyes toward the left side before moving around. So they will be ensuring that they are moving the head to the affected side. What we need to do, searching exercise. We train the patient to search. Don't say that the patient visual ability is good. No, patient with visual field, they need to compensate this problem with their visual field. So they need to do a lot of searching exercise on the affected side. So you need to do a lot of exercises. Explain to the patient, your intervention is not only for the upper and lower extremity. You have problem with the vision. This will improve your quality of life. We need to work on improving your visual abilities. Some of the exercises that I show you also, these exercises can be used for visual field as well, and for the patient to move their head and search on the affected area. So you can use your exercise. You can also use some of the machine which will help you in the searching exercises as well. Now, for the visual neglect, I will just give you an idea. Patient with visual field, we said we do the confrontation test. We do the confrontation test. We ask the patient, can you see my finger moving? Point to the finger which is moving, okay? And I will check all the quarters. For patient who has problem, they keep looking in all direction, I will ask somebody to help me and the stimulus will come from behind. For visual neglect, it is different. It is depend on the attention of the patient. So from the name, visual neglect or visual inattention, it is depending on the patient ability to pay attention for the affected area. In the visual neglect, I have one patient, the patient sitting here, who was doing the exercise, and from there, my story with visual neglect started. I was treating a patient, and I told the patient to put the object in their place, and he did not come to this side. He did not come to the left side at all. And I told him, okay, continue the exercise. He started to put the object over each other, and he started to build bridges. I told him, there is no space at all? He said, no space at all. And he did not come to this area. This may make me to question myself. Is this his visual field? Or what is it? Because in patient with visual field, they will do the exercise. They will complete the whole exercise. Maybe they will consume more time, but they will do it. But patient with visual neglect, it's a unique diagnosis. It is different, and it needs more intervention from you. Now we will stop here. and we going to come again for the visual neglect at 6:15. Within this coming like 3 minutes, I will be waiting. If you have question for the visual field, I will be happy to answer it. And for other colleagues who don't have a question, at 6:15, inshallah, after the prayer, we will meet again. Thank you very much. Assalamu alaikum wa rahmatullah. Okay, we will continue our topic. Now we are talking about the visual neglect. We need to know what's the difference between visual neglect and the visual field, because most of the time there's mixing between the two topics. If this task will be given for patient who has only visual field, purely visual field, the patient will be able to do the task. It will not be difficult for the patient because they are not able to see on the right side. What they will do on the left side, sorry, they will just compensate. So the patient with visual field will compensate because the patient, he has awareness about his problem. Visual neglect, which is called visual inattention, spatial relation, unilateral neglect, it is a condition experienced by the people who had brain injury, including stroke, head injury, and other condition. It is when a person ignores the whole world, like on right side or left side. Most of the time you will hear that visual neglect is happening for the left side, which is right for most of the cases. But you can find it with patient who has right visual neglect as well. It's more common on left, but also on the right, it's there. So it's more common when patient having right hemispheric lesion. It is most of the time happened in the temporoparietal junction and accompanied with parietal lobe infraction or parietal lobe affected for those patients. But it can be also when patient is having also frontal lobe. The neglect happened when area related to the attention, really area responsible for attention will be having damage, like the parietal lobe, the frontal lobe. Also, if the patient having also a problem in the stroke affecting the thalamus, they can have it. That's why the visual neglect, it is unique and different from one patient to other patient. The key word here is attention. Patient, they don't have visual attention. That's why they are having this part of neglect. Those patients can fail to include the neglected side in movement. And the literature suggests that patients with right CVA, right stroke, they are having 30 to 70% of percentage to have visual neglect. And patient with left also CVA, affected the right side, will have 20 to 60%. And I would like you to look to this percentage. 30 to 70, 20 to 60, it's very huge. It's not precise. Supposed to be when we are talking about percentage in research, it will tell you 60 to 67, 50 to 53. Why this huge variation in the number? Because those researchers, they use different assessment for the visual neglect. There's a lot of assessment for visual neglect. So they get different results. For the patient with a stroke, 66% of the patient with the right CVA, they are having visual neglect. So most of the time when you have a stroke, expect the patient might have neglect on the left side of their body. They are neglecting the left side of the body. This is a neurocognitive disorder which is associated with longer hospitalization. Patient will need more length of stay because they are not able to walk in a short time. They are not able to do their activity of daily living, so they need more time. Those are the patients that with stroke, a therapist who's not having a good experience will say this patient is not cooperative. I remember one of the patients who has severe visual neglect. He was very difficult to deal with the patient, and we could not understand his behavior. He's refusing the exercises. He was not safe at all. But then we knew that this is because of the visual neglect and because the affectation of the right hemisphere. Because in stroke, if the patient has right stroke, right hemisphere, it's different, totally different than the left hemisphere stroke. The one which has more complication if the patient has in the right brain, right side of the brain, he will have even change in his behavior as well. So this is good also to know. The rehabilitation outcome is poor. You will not expect the patient to have huge improvement. They are having higher risk of fall. They have difficulty in navigation because we said neglect. It's also related to the parietal lobe. So those patients, they will have a problem in navigation, going back to their room, going to the area that they want to go to. And the neglect is not only one type. There is neglect for the body part. This is called body neglect. There is another type of neglect which is within the arm reach. Within my arm reach, this is my arm reach. If I am reading a book or I'm looking to the computer, I will only look to the right side of the computer. If I have the plate for the food, I will look only to the right side. I will eat only from the right side, but I will not touch the left side. This is called peripersonal visual neglect. And there is a third type of neglect. If this is for the far object, it's called the extrapersonal, not within my arm reach, after the arm reach. If I'm looking to the wall in front of me, I might see only the right side of the wall, but I will not pay attention to the left side of the wall. So there is three types of neglect: body neglect, the side of the body; peripersonal, within my arm reach, like within 50 centimeters in front of me; and extrapersonal. Is the patient has possibility to have three of them? Yes. If the patient has possibility to have two? Yes. So those patients, they need a lot of intervention and options for the treatment. There is a condition called anozoagnosia. Anozoagnosia, it is a condition that you will know if you tell your patient why you are coming to the hospital. He will tell you, I don't have anything. I just come to check my temperature. No, you have a stroke. You come to me in the wheelchair. No, I come to you walking. I did not use wheelchair. I am healthy. I explained to you yesterday you have visual problem. No, I don't have any visual problem. I can see everything is good, and I'll go back to my job. Now you will think that the patient has a psychiatric issue, while the patient has anozoagnosia. Patient is not aware about their insight. They don't know about themselves. So this is one of the conditions which is common with those patients with severe visual neglect. Neglect is a heterogeneous condition because it is different from one patient to other patient. How it's present in one patient from the other patient, it is different because the area in the brain affected will be also it's different. If you have patient with middle cerebral artery stroke, might have neglect because this is the branch also doing the nourishment for the parietal lobe. It is affecting your ability to process the information, how you deal with the information. This will be affected because of the neglect. Now, how I will know that this patient is having visual field problem or is it visual neglect? How can I identify the problem? Now, here is the answer. Now, patient with visual field defect, they have a problem with seeing. They cannot see. They're having blindness in the left side, okay, or in the right side. We will talk about the left now. Patient with visual neglect only, they can see. When you do confrontation test, can you see my finger moving? Yes. Can you see my finger moving? Yes. And you need to do the assessment for the patient in a quiet area and not having a lot of distraction. They will tell you if the patient has only visual neglect, yes, I can see. Yes, I can see. But if you bring the same patient with visual neglect to the gym and it's crowded, there's a lot of like equipment, and you give him some task, you will observe that he's only focusing on the right side. And maybe he's turning his head only to the right side, not to the left. It's because this area needs more attention, and he has problem in attention, visual neglect, visual inattention. Is it in the cognitive impairment? Patient with visual field, because the damage in the brain, remember, for visual field, it's in the occipital, or part of the parietal, or part of the temporal loop. So usually the cognitive is not affected or could be minimally affected. But for visual neglect, the cognitive ability is affected. Why? Because this is visual inattention. The attention for the patient affected, that's why he has the neglect. So mainly the attention and the type of attention, which is the sustained attention, is affected. Is those patients aware of their problem? For visual field defect, when you tell them you have this problem, they will tell you, yes, yeah, okay, I understand it, and they will get it. But for visual neglect, they are not aware. That's why patients with visual field, they can improve because they are aware, they are more independent, and they can compensate. But patients with visual neglect, they don't have awareness, so they will not improve and they cannot compensate. The improvement will be poor improvement. Now, how can I assist the patient with visual field? Confrontational test. How can I assist patient with neglect? Using the star cancellation test. There is more than one test. Star cancellation, we will talk about it. It is about assessing the peripersonal space in front of the patient. Another way of assessing the patient, you will let the patient sit in the gym or in the therapy room and tell him, now I would like you to name for me 10 objects in the room. The patient with visual neglect, they will give you maybe 8 or 7 objects on the right and only 2 objects on the left. So most of the object he called, it was on the right. So this is indication for the neglect. So if I ask the patient to name the object in the room, this is what type of neglect? Is it peripersonal or extrapersonal or body neglect? What do you think? This is which type? I ask the patient to name 10 objects in the room. This is extrapersonal neglect. If I use a piece of paper and assist the patient for neglect, this is what type of neglect? For assessing the patient on the table. This is peripersonal, extrapersonal, or body neglect. What do you think? Okay, this is peripersonal. Okay, now the third type of neglect, there is assessment called the Bergego scale. This is it's a checklist of a question that you will ask the patient or you will observe by yourself. It is in the resources that I will share with you. And if the patient has purely visual neglect, I advise you to use the 3 assessments: star cancellation, also ask the patient to call object, and the Bergego scale, because that one, it is about the body neglect. I seen one patient with body neglect, and she didn't have peripersonal and extrapersonal neglect. That one with body neglect has good cognitive ability. But the patient, if he has neglect for the peripersonal, extrapersonal, expect the cognitive to be affected. Why I need to do early detection for those cases? Because this will help me to provide a suitable intervention, because those patients, and we feel sorry for them, they are not receiving proper rehabilitation. The therapist will think they are not cooperative. They will not be extended in the length of stay, because they will say this is the hopeless case. And this will help you to work with the team. All the visual rehabilitation depend on the teamwork and interdisciplinary work. We need to educate the family that your father or your brother is not pretending, because many of them, they will tell you he's pretending. No, he has serious problem, and this is his problem, and this is your role, how you can help him or help her. Also, those patients, if they are having visual neglect and they are receiving therapy in general center, I will tell them you need to be in a specialized center to receive the proper care. Those patients, if they are not identified, you will have a lot of falls. The patient will have falls and fractures. The patient will have shoulder injuries and subluxation, because they are having issue with their safety. This patient, in simple word, he can be sitting on the wheelchair and his hand is in the wheel. He's not aware about the hand. Or he can sit on his hand. Or this patient, he will have malalignment. Okay, for example, I'm sitting straight. Those patients, you will find them sitting like this on the right side. Why? Because their ward in this area, they are not having attention here. So they will do like this. And this reminds me to tell you about, or to remind you about the midline shift syndrome. Patient who's not able to sit straight. Every time in the session, you tell him, sit straight. He will do like this. Sit straight, sit straight. They will not sit straight because this is straight for them. It is on the affected side. Their ward in this area, so they are sitting this way comfortable. So how you can do assessment for those patients with midline shift syndrome? You will use a ball pen or object until the patient, when I move the pen around you and the circle around you, you just tell me when it's in the middle. Those patients, when you move it, they will not tell you like what I'm sitting now, it's in the middle. No. Okay, when you move it, they will tell you, yes, it's in the middle now, while they are not sitting straight. So we need to be alert for this problem. And for those patients, it's recommended to use with them prisms and as well also mirror therapy for those patients. The patient who shaving part of the face, or the lady who's putting the makeup on one part of the face, or eating part of the food, this is patient with visual neglect, not with visual field only. But just be reminded that the two conditions, it can come together, and this will make the case more difficult. So again, the history, we need to ask the family for the history. They will tell you after a stroke, he cannot see on the left eye, like the visual field. He's not able to see. He's not cooperative. He's becoming moody. He is. He's not listening to us. He is not paying attention. So you need to look for this one. Also, for the patient with visual neglect, it's common for them to have this position, that to have the head tilted to the non-affected side. As we said, they have some shift in their sitting. Some of those patients, you will observe that when they are sleeping on the bed, they are sitting on the edge of the bed as well. There is a lot of assessment, standardized and non-standardized assessment used for visual neglect, like the behavioral inattention test. It is a complete battery. Catherine Bergego scale, National Institute of Health stroke scale. It includes also the neglect assessment, cancellation test, and other tests. The assessment that we seen in the video about visual inattention, this is called assessment for extinction. What you can do with patient with visual neglect, you can move the two fingers together. Patient will only identify the one in the non-affected side, and they will not pay attention for this one. So this is called extinction. It is for visual neglect, but not all patients with visual neglect, they have the extinction. Moving two fingers together, patient will identify one. Even from the back, tapping on the shoulder, he will tell you, yes, right. Tapping on the other shoulder, he will tell you, yes, left. Tapping both, he will tell you, right, only. They will not identify the left. This is called extinction. Extinction. And that was in the video saying this is inattention, but actually it is part of the assessment, not the whole assessment. The research suggested to use the more than one assessment for the patient, but the assessment will take long time. That's why we prefer to use something very simple and straight for those patients through assessing the very personal space, through assessing using the star cancellation. The mirror, there is a question here, mirror will be useful? Yes. Mirror will be useful for the patient with the midline shift syndrome, because patient with midline shift syndrome, they will see they are not sitting properly. They will adjust. They will have visual feedback. It will help them to adjust. If those patients with visual neglect, they have problem, but you should not put the mirror in front of the patient. It should be on the non-affected side, on the right side with angle. If I am sitting here, the mirror need to be on, let me move this one. The mirror should be at this angle. So it will not be in front of me. No, it should be an angle 45 degrees. So I can give the patient feedback about their sitting. Okay, star cancellation. Why star cancellation? Because the star cancellation need a lot of attention. And our problem is visual inattention. So you need assessment like this assessment to use it with the patient. Either star cancellation, bill cancellation, letter cancellation. This one is called the Albert assessment or line cancellation, but it's not recommended because it doesn't need a lot of attention. Patient can cross all of the letters, but this one patient required to cross the small letter. It's difficult for them. It will give you that this patient has neglect. We'll talk about it. Another type of assessment is the drawing a clock, drawing a home. You will tell the patient, I want you to copy this clock, this home, and this a flower. But this is not applicable with many of the patients because some of them, they are having a stroke affecting the dominant hand, which is they are using for writing. So it's not really applicable for the patient because of the handwriting. And I remember one of the videos, I would like to advise you to look for the visual neglect cases. There's some cases on the YouTube. One patient, when his family talking to him, he has left visual field neglect. When his family was talking to him about memories in the past, he was able to remember the things which happened on the right side. And he could not remember the thing which happened on the left. So you see how it's severely affecting the patient life if the patient has visual neglect. It's affecting the whole life of the patient. Why star cancellation? It's a valid and sensitive assessment. It will not take from you more than 5 minutes, and it assists the very personal neglect. But the study saying that 80% of the patient who has visual neglect using the star cancellation, they are having confirmed with other types of neglect like the extrapersonal cancellation as well. But for you, it's important at least to use something very simple for the patient. How we do the assessment? Okay, the assessment done for the patient by placing the piece of paper for the patient, this one. We will present it in front of the patient. The patient will be sitting, and we will present it in front of the patient. And what I will do, I will cross for the patient 2 stars, 1, 2 stars, the small stars only. There is 56 stars. I will cross for the patient 2. I will tell him now, I want you to cross all the small stars. Now, the patient with severe visual neglect, they will only cross few stars here on the right side, and they will tell you, I'm done. You will not give the patient any additional instruction. You will not tell him, don't turn your head. No, look more. No, he can turn his head. He can look everywhere because he will not do it. If he has severe neglect, he will not pay attention to the left side. If I am expecting neglect on the left side, I should not be standing on the left side of the patient. I should be standing on the right side of the patient, and the patient will do the star cancellation. Some patient only will finish only this part. If the patient missed 4 or more small stars, then this is indication for visual neglect. Could be on the right side visual neglect, or on the left side visual neglect. So if he missed 4 stars for only the small stars or more, this is indication for visual neglect. Now I do star cancellation. I need to do the confrontation test for the patient. The star cancellation will tell me the patient has neglect. What if in the confrontation the patient did not see my finger in the left side? So what does it mean? Patient has visual neglect and visual field problem. So the patient has 2 problems. What if the patient do the star cancellation very well, no problem, and could not see my hand moving on the left side? So this is visual field only. If the patient has problem with the star cancellation and visual field was good. Patient has visual neglect only. So 4 cases. Patient has normal vision, no visual field, no neglect. Patient has neglect only. Patient has visual field only. Patient has both of the problem together. And this is more complicated. Now, proper intervention. How we do the proper intervention for the patient? In many patients, there is good recovery if we do a proper intervention for those patients, but the general outcome will be poor, affected with the visual neglect. The level of recovery depends on the quality of intervention. Input from healthcare profession and carer is important. You are treating the patient, for example, 3 hours. They are coming, for example, in our facility for occupational therapy, physical therapy, speech therapy, and some patients, they receive more, but average of 3 hours. What about the remaining 21 hours? The patient will be in the room. You need to train the patient, the family, how to deal with the patient, how to do stimulation for the patient as well. This is one of the way for doing education for the patient. You will do video taping for the patient during the exercise. Then you will tell the patient, I would like you to show you how is your performance during the exercise. This is to build his awareness about his problem. If he has good awareness, the patient will show good improvement as well. So video feedback. Take a video with the patient cell phone or something and show him that he is missing the part on the left side. So he will build awareness about his problem. Mirror therapy, but not using the mirror in front of the patient. It needs to be in angle because I will use the intact vision for the patient. Training on the searching and especially for the sustained attention. You will do exercise for the patient, searching exercise, and this exercise will be targeting the affected area, the left side to be affected with more training and searching exercise. That's why education for the patient that you are admitted here, not only for hand and leg exercise, no. You have visual problem, you have neglect. If we did not treat your neglect, you will not improve. It is about your brain paying attention to the whole body. Some patients with visual neglect, they think that they can walk. They move the right leg, they think they are moving the left leg, and they fall down because they don't have awareness about the movement. Some patients with body neglect, they don't move the hand because of the body neglect, but they have the ability to move it. That's why cognitive training is very important for those patients. Some intervention can be used, like using vibration on the affected side, on the neck, using hot packs, cold pack. This is effective, but with intervention, but with short effect. It will help the patient to pay attention to the affected area, but with short effect. Prism therapy, going back again to the prism therapy, for the patient who has the midline shift syndrome and patient who has neglect, they are looking to this side, it's recommended to use the Yolk Prism. Take the prism, as you observe again, see how it is shifting the picture. This Yolk Prism, I will show it to you. This is the base of the prism. So the picture will come to this side, and this is the apex. This is the apex and the base of the prism. This is for the patient who has right hemianopsia, because it will take the picture from left. Patient who has left hemianopsia, it will take the picture from left to right. It can be hanged on the glasses like this, and patient will wear it. Now, if I'm going to point to the camera is shifted already. So this is the way that it will be used for me. For example, even the computer itself, it is shifted as well. So this type of a prism will help you, to move the picture. It will be making shift for the picture, and it will help the patient to adjust their position in the setting. You need to try it by yourself, and you can see the effect for this prism. Actually, this one, it is with 10 diopter, 10 degrees of shifting for the picture. But this one, let me just ensure, because I have more than one Jukti Prism. This one will help in moving the computer from here to there. So it's shifting the computer from the left, it's moving it to the right. So if those patients, they are having problem in their setting, it will help them to adjust their setting and shift their trunk. You can observe it with the patient when we use with them the prism, that there is effect after the prism. It will continue until like 1 hour that the patient is looking to the affected side. It's really helpful for the patient. This is called the Yolk Prism. And this is the Ilibili Prism as well, which is used with visual field mainly, but also with visual neglect, it can be used. If the patient has visual neglect only, he can see the whole picture, but he has neglect with the affected side, you can use with them the concept of the concept that we are using with constraint-induced movement therapy. You will cover part of the vision, and you will let the patient look, force them to look in the neglected side. If the patient has neglect only, if the patient has neglect and visual field, it will not work. But if the patient has good visual field but has problem with the neglect, you can use it. Positioning will not cost you anything. When the patient sits on the table, ensure that his hand in front of him, he can see his hand. In the room of the patient, make the patient sitting in a room that when the nursing coming, anybody coming to the room, they are facing the patient from the affected side. They are coming to the affected side, and the patient forced to look to the affected side. Every time somebody come, he forced to look to the affected side. There is some instruction also, encourage the visitor to sit on their affected side. Redesign the room and put the interesting and important thing for the patient on the affected side, for example, on the left side. Put a line or tape down the left hand side of book. If there is the patient is reading a book, put a line also on the left side, so the patient will know that he reached the end of the line. Colorful light also can be on the affected side. Game and puzzles when you are with the patient. Grasp the hand of the patient also, and let him feel that you are sitting on the affected side as well. For the visual neglect, we need to know that it is misdiagnosed and patient not receiving proper evaluation and intervention. Star cancellation is recommended to be used with those patients, and there is a need to use multiple interventions techniques for improving the function of patient with visual neglect. So this is very important for us to know about the visual field and visual neglect. Please let me know if the visual field, the blindness and visual neglect, is it clear for you or you need more explanation? Please don't hesitate. I want you to, if something is not clear for you, we can repeat it, because it's very important for me that you understand the concept. So please answer me through the chat. Is it clear for you or you need more explanation there? What's your question? If you have any question, just let me know. So visual field, blindness. Visual neglect, it's attention. Patient could be able to see everything, but they have a problem in their attention. Now, low vision. Actually, okay, here, okay, good. We have a question here. Good. I like questions. how to assess if patient has visual field and neglect? Okay, excellent. You will do star cancellation, the star cancellation paper. You have it also in the format. Put it in front of the patient. Give the patient ball pen. Tell him now, I want you to cancel all the small stars. The small stars is 56. The patient will start canceling the stars. If the patient missed, he will tell you, خلاص, after 3 or 5 minutes, he'll tell you, خلاص, I'm done. You will not tell him, okay, try again. No, خلاص. If the patient missed 4 or more stars, this is patient has visual neglect. Okay. Other way of assessing the visual neglect, but this is for the extra personnel. Ask the patient while he's sitting in the room to name 10 objects in the room. If all objects or most of the objects on right side, then the patient has neglect on the left side. Another way also to assess through using the Catherine Bergego scale, which is in the resources for the body neglect. Now, we're done for the neglect. Visual field, we will do confrontational test. As we said, we will divide the vision. This is one half, and this is the second half. Sorry, second half. So we have right, left, upper, and lower. I have for my vision now, right, upper, and right, lower, here, down. Okay, let me go back, right, upper, right, lower, and left, upper, and left, lower. What I will do, I'll tell the patient, look to me, please. My head should be at the level of his head, and eye should be at the level of his eye. Tell him now, don't look to right or left. Just tell me if I'm moving the finger, yes or no. Point to the hand which is moving. And the patient will tell me, okay, the patient could identify this, but could not identify this. Could identify this, but not identify this. The patient has hemianopsia, or the patient might have quadrathanopia. So by assessing through the visual neglect assessment and visual field assessment as well. Okay, is it useful to grasp his hand toward the neglected side? Yes, it's good. You can, for example, the patient is sitting with you, you can grasp the left hand, the affected hand, and with making some pressure to let him feel that there's something. You know, some patient with visual neglect, you might be surprised when you tell him, when you tell the patient, okay, where is your hand? He will start searching. He will start searching, looking for they don't know where's the hand. So it's any technique that you can use will be good for those patients. Something to add, that if all of this failed, the patient could not pay attention to the left side, and you change the furniture, you tell the family to approach him from the left side. This did not work. This is called remedial approach. You try to improve. If this did not work, go to the compensatory. Let the family approach him from the non-affected side. So we need to facilitate the life of the patient. So if we can stimulate him to look to the left, it's great. If the patient has a severe case, we try therapy, like after 1 year, and there is no improvement, tell the family to approach him from the non-affected side. Is it useful to grasp? Okay, we answered this, or only to tell him verbally to use left side? No, it's good to use all technique. Tell him to use it. Tell him to look, grasp the hand of the patient. Use hot bags, maybe cold bags with the patient. Any technique can be useful, because those patients they have major problem with visual neglect, and they need your support. Okay, thank you very much. Now for the low vision rehabilitation. When we talk about low vision, can you tell me, in like, the word low vision, what does it mean for you? Does it mean that the patient is blind, or what does it mean? Low vision. When we talk, you hear about this is a low vision case. This is a low vision clinic. What does low vision mean for you? Is it any problem with with visual acuity? Is it a problem with what? Visual field, visual acuity? What's the, it should be with what? To say this is a case of low vision. What do you think? What comes to your mind when you hear low vision? Now, I tell you low vision. What does it mean? Eye itself. Visual acuity. Great. If we have more answers. So people will think about the eye. People will think about the visual acuity. Okay, good. Efficiency. Okay. Actually, when we talk about low vision, it consists of two main parts. One of them, or it is actually three parts. One of them is the visual acuity. That the visual acuity, it is very low, it is very poor. And the other one is the visual field. And the third one is the function. So visual acuity, visual field, and the function. What's the source of this problem for the patient? The source is the eye and could be the brain. It's not only the eye, but low vision can come because of brain problem, because of the occipital lobe problem. I told you about one of the patient who has bilateral occipital lobe lesion, and the patient has blindness. So this patient has low vision. Patient with hemianopsia considered as also, this is low vision. How it's identified? The low vision defined through the World Health Organization, people with low vision as having visual acuity less than 6/18. After best correction or visual field is less than 10 degrees from the point of fixation. It is very simple. I'll explain it to you. If you do the visual acuity assessment for the patient, you come and you do this assessment for the patient, and you find out that this patient visual acuity was 20/100. So it is 20%. This is called a low vision case. If it's lower than 6/18, just divide using your calculator. 6/18, it's equal to 0.3333. If the patient visual acuity is less than 0.3, this is considered a case of low vision. But you cannot say a patient who come to you and you do assessment in the OT or in the BT clinic that this is a case of low vision. No, patients should be wearing their glasses, and these glasses should be good for them, and the environment in the room should be very good. And after that, even as occupational therapist, as physical therapist, we cannot say this is a low vision. I can say this patient, I'm suspecting that he has low vision. He needs to go to the optometrist to confirm. If he go to the optometrist and confirm, this patient need to go to a low vision clinic to get the intervention. So it's very important. Patients should wear their glasses, and we do not give any judgment for the family. And you need to learn how to do the assessment for visual acuity. And after you learn how to do the assessment and you get the score, you just divide the score. 20/125, you use the calculator. 20/100 is 20%. 20/80 is 25%. 20/63 is about 0.3. So if the score of the patient below 0.3, this is considered low vision. This is one. The other case, if the patient can see for the visual field, but it is less than 10 degrees, yani, meaning that the patient can see only in front of him and only like he can see in a small circle. Like if you are looking like this, if you're looking like this, patient is only can see in the front of him and very limited vision. This is called low vision. This is as per the World Health Organization. Another identification, it's about the function. If the patient is not able to do the function, this is a case of low vision. So this patient with problem with visual acuity, this patient with visual field, and it's affect their function. So either low visual acuity less than 0.3, low vision, a visual field is severely affected, low vision, function is affected, low vision. Like hemianopsia, patient cannot see left side or right side, but is it affecting their function like driving and the quality of life? Yes. So this is part of the low vision as well. This is the definition of the low vision. This is some of the measurement for low vision. Not all cases is the same. Some cases will be normal to near normal. If the patient has vision 0.3 and more, to like more than 30% to 100% of vision, this is normal to near normal. If the patient has less than 0.3, this is mild low vision. There is moderate low vision, there is severe low vision, and there is blindness. If the patient cannot see at all, this is called blindness. So not all cases with low vision is blind. Some cases with low vision is blind, but not all. For example, this one is 6/6 or 20/20, which is 6/6 mean the assessment done from 6 meters, 20 from 20 feet. This is normal vision. 12/20, it's 0.6. Okay, it's affected, but still it is within the acceptable range. The patient can maybe use the book closer for them. 5/20, this 0.25%. This is low vision. In case the patient using glasses, proper assessment done for the patient, this is called low vision. And I am, as a occupational therapist, I cannot assume. I need to send him to do further assessment. And this one, 0.05, this is it is severe low vision. This is example of low vision, how is the picture could be, and we can see here as well. And now for the full darkness, the patient cannot see at all. Causes of low vision, occipital loop can cause the low vision. What about the eye itself? Just to give you a brief, that some changes occur in our eyes and vision as we get older, and it's part of aging process. People more than 65-year-old are at higher risk in developing the low vision, and there is variety of disease and disorder, injuries and birth defect that affect the eye can be the cause of low vision. Not only that, old people, there is some like children, they're born with a low vision problem, like some of the condition which is genetic problem in the vision. Most common cause for low vision is age-related macular degeneration. This is related to the age. While the people they're getting older and older, the cells of the eyes might be affected. Cataract, glaucoma, or diabetic retinopathy. We will talk about them briefly. Okay, here Fatima saying there's a problem with sound. If the sound is not clear, please write number 2. If the sound is not clear, write 2, please. If it's clear, write 1. If clear, 1, please. Not clear, 2. Okay. Okay, Fatima, if you can check the okay, Fatima and Noura. Okay. Now, is it clear or no? If there's still a problem with the voice, with the sound, let me know, please. I see there's 4 of the colleagues, 2 of them said the sound is clear and 2 said it's not clear. So please, we need the participation of others. Now, okay. Okay, please, if it's not clear, write 2 so I can pay attention if there is any issue. Okay. One of the problem, which is, and please don't hesitate anytime, just let us know, please. Thank you. So one of the problem is called the glaucoma. Glaucoma in Arabic, الماء الأزرق. And it's called, in Arabic, it's called سارق, because it is stealing the vision, and it's like, it's called in Arabic like سارق, or it's in English theft, because it is stealing the vision and people, they don't know, they don't realize that it's there. This is because of pressure which is happening on the anterior chapter of the eye. We said the eye, there's anterior and posterior chapter, and this pressure affecting the lens, that the lens will be pushing the liquid in the eye, and there will be pressure on the optic nerve. The optic nerve, when it's pressured, there will be damage to the eye cells, and the patient will not be able to see at the edges. The patient will be able to see only in the middle. So this is one of the condition which can be avoidable by regular checkup to the ophthalmologist by the old people to check the pressure in their eyes. So we see how, and this is irreversible. If it happened, this is irreversible. Age macular degeneration, it's happened because of degenerative acquired disorder of the central retina. It's occur after 55 years, and it causes significant and irreversible loss of the central vision. As we see here, this one, patient will not be able to see in the middle, not on the edges like the glaucoma. And this is diabetic retinopathy. Patient will be able to see, but there's some patches patient will not be able to see them. This is how patient with diabetic retinopathy can see. See how it's annoying. This is from the eye itself. And cataract. Cataract because of the white material, which is the whitening which happened on the lens, and it make inability for the people to see. Clouding form in lens due to denaturing of lens protein, and this is require surgery for the patient, and they replace the lens for the patient to be able to see again. But the previous one is irreversible. In low vision rehabilitation, now, it is relying on the compensation of the function for the patient. It's help the patient through the devices to maximize their remaining vision and to live independently. Patient who cannot read at all. If you leave this patient alone, he needs somebody to be with him 24 hours. So you can give him some devices, which we will see some of them, to use them and to be able to do the function by himself, or he cannot go to the bathroom, he cannot go to the kitchen. They need some assistive devices to help them. Low vision devices can be divided into optical and non-optical devices. It's optical, which is used on the eye, and non-optical devices, not necessary to be lenses at all. The optical devices can have one lens or more than one lens as well, to modify or enlarge the object of interest. There is something that we need to know about the magnifiers, which used to make the picture big. This magnifier, it is used to make the picture bigger, but not clearer. If the patient, if you are looking for, the patient would like to read a sentence, but this sentence is not clear, it's not written clearly, the magnifier cannot make it clear. It's only make things bigger. So there's sometimes misunderstanding. People will think that the magnifier will make everything clear. No, it will make it bigger. The original sentence should be clear. Non-optical devices does not have any lens system, but will make it easier to see object and will make the life of the patient is easier. This is example for the optical devices. This is called the spectacles. It's used for reading. And the patient with low vision might need to hold the book very close to their eye. It could be up to maybe 3 centimeters when they use these spectacles. So it is not easy to be used, but sometimes it is the option for the patient. As you see here, there is magnifier. There is many types of the magnifier. This is the hand-held magnifier. For example, this one, the patient will use it with the hand. And it has light as well. The light will help to, the patient to stimulate their visual ability, and they will have better function in the vision as well. Not always patient can use the hand magnifier. What if the patient has tremor or has weakness? So you need to use something on the table. This one, it's hold, but it is on the, it's with a stand. It will be on the book. And patient will be using this magnifier for reading. So you need to consider the patient functional ability, the task that the patient is doing, and the time that the patient will use this, this device. For example, if a patient will go to the market and would like to know the price, they would like to know the price of the, like a cane, that they would like to buy a cane of food, and they would like to know the price. Are they going to take this one with them? No, it's very big and bulky. Are they going to take this one? No. We might tell the patient to take maybe this one or something very simple, very small, because the task will be quick task. So it depends on the task, depends on the duration for how long you need to use it, depends on your physical ability for the patient also financial abilities as well. This is another part which is called the dome magnifier. And this is used for the ladies also, or for people like in the, what they call it, in the using the strain, or في أعمال الخياطة, in the strain also they use it. It will be hanged hanged, and the patient will be using this magnifier for making the object is bigger for the patient. Non-optical could be your phone is non-optical device. We will go after a while for the break, but we'll talk about the devices first, then we'll go to the break. Your cell phone is non-optical device because you can use the option in your cell phone and make the screen, make the writing bigger and make it bolder. The phone, if you change the numbers to have it bigger numbers, if you use a stand, this is also non-optical devices. If you use a hand watch, which is has big numbers and it has speakers, like this hand watch and this clock, it has big numbers and it has speakers. Patient can hear the time. What's the time now? Some devices, which is like the signature guide, which can be used for the patient with low vision. Also the letter writer, there is some papers for the patient with low vision that it is bold and will help the patient to see where they are going to write. Not all patients with low vision cannot write. So it's, as we said, it's level of low vision. Okay, this lamp on the right side and on the left side, which one you would like to recommend for the patient? Right or left? What do you think? Right or left? The light with spreading the light, or the one which is focusing the light on the task? Which one? Okay, left. Left, yes. We don't recommend this type of lighter for the patient, but we recommend this one, which is focusing the light on the task, and patient, they will be able to see. And here is the Braille way for writing for the patient. and this device, patient can use it to install the a book as a PDF in the flash memory, and this device is going to read the book for the patient. Actually, there is a lot of options, but we need to search and we need to look for these options. This is the closed circuit TVs, which will help the patient. The patient will put the book here and he can read from the screen, and will help the patient to write or to do signature as well. It will help the student to read the from the board, which is far from them. They can read on the what you call it, in the PC or from the paper, and it will change the contrast. This is black writing on the white paper. This device can change it to make it white writing on a black paper. And some of them also portable and can be held by the hand. Now we're going to stop here, and after the break, we will talk about some advices for the low vision that you can provide for your patient. And after that, we will talk about other also assessment for the color, contrast assessment, and sensitivity, which is very simple topics, and we'll give you idea about the visual assessment report, visual assessment form, sorry. So thank you very much, and we will continue at 7:30, inshallah. If you have any question, you can raise it now as well, and we will have time after we finish. We will have time also for the questions. Thank you. Assalamu alaikum wa rahmatullah. Inshallah, we will continue, inshallah, after Adhan. Allah. Okay, we talked already about the devices which can be used for the low vision, including optical devices. Something you will use it to magnify the picture, to increase the size of the picture, and this could be something that held by the hand, something maybe hanged for the patient, and could be like one of the magnifier with light, without light. Something could be very simple when you go to the market, or something for reading a book. Could be spectacles as well, not like the normal glasses. No, this is called spectacle with magnifiers. So depend on the patient need. The non-optical, anything in the market you can use to facilitate the life of patient with low vision. It's not necessary to have it in the catalog for low vision. No, you can go to the market and find that this type of a clock is good for the patient with low vision. This type of something like support for activity of daily living is helpful for the patient. And the closed circuit TVs, which is something very expensive, but they have it in the labs of the, for example, in some of the schools to support the patient who has low vision. Some of them are portable, and these devices is very good, and it can also change the contrast. It's good for you also to be familiar with some of the feature for patient with low vision in the cell phones. Like what I know in the iPhone, there's a lot of features for the patient, including changing the contrast. If patient has difficulty to read the writing which is in black on white paper, it will change it for the patient. It will change the contrast for the patient. So it's worth it to know what can help the patient. When using the light, this position is not recommended to have the light from the right side while the patient is writing, because it will make shadow for the patient. This position is good, opposite to the hand which is holding the pen. And this position is good also. The light should not be in the eyes of the patient. It should be on the task, on the book that the patient is reading. Also, there is no problem with moving closer. You will find some families who has patient with low vision, and especially children, they will tell them, no, don't go close to the TV. Don't bring things closer. No, this is a way for them to compensate, to be able to do the function. So no problem in coming closer and in doing the task through bringing the object near to them. Actually, one of the technique for the low vision that to decrease the distance. If you are reading a book, and this book, it is far from you 50 centimeter. If you bring it to 25 centimeter, you are maximizing the picture by the double. You're making magnification. You're making the picture near for you 100%, because you are moving it closer to you. So moving closer, there is no issue with moving closer. Also the contrast. Think about the contrast. When somebody is having low vision, you cannot, for example, put for him the rice, which is white, usually white rice, in a white plate. You need to think about the contrast for the object. If the patient going to go to the stairs, and the stairs color is white, you can put a tape on the stairs so the patient will not have any safety issue. Now, for the teachers, especially for the children who has low vision, you need to advise the teacher while explaining, while writing, he need to speak. So this child with low vision will benefit from the visual stimulus, which is weak, and from the auditory stimulus. The student also need to be seated in the front chairs so the patient can see and can participate. He should come closer to the chalkboard as well. Also, when you are giving information for the patient with low vision, ensure to provide simple and clear instruction or information for the patient. You need to describe what you are talking about. It is very difficult to grow up a child with who is blind or having severe visual problem. So there will be a lot of effort in the parents and especially on the mother in training the child. They need to experience. Don't prevent them from experience and know what is surrounding them. So they need to rely more on their sensory abilities. They need to play. They need to touch things so they can learn. So they should be given the chance to explore the things around them. For the low vision, actually, it is a huge topic, and this is only an introductory information for you to know what is the low vision and its levels, and what if the patient has low vision, what options is available, and also what instruction need to be educated for the patient and for the family, and where to refer the patient if the patient has low vision. Client with low vision will need special devices to improve their independence, and most of the time these devices is expensive, and we need to know the exact demand for the patient, so we will be able to select the appropriate device for them. Optical and non-optical devices recommendation depend on the client visual cognitive abilities and tasks to be accomplished, and general advices such as lighting, positioning, and education training style will help the client and their family for better function. So these advices will be helpful for the patient and for their family for how to deal with the patient with low vision and how to provide them the needed support. Now, the remaining condition that we're going to speak about them, we have the color blindness. There is many people, they are having color blindness, but they are not aware that they don't recognize the red or green or blue color, unless sometimes they have to do assessment for the color blindness. It happened when one or more of the color cones cell are absent. There is, we said, 3 types of the cones in the eye itself. The cones which is responsible for close vision, and it's responsible for identifying the color. So if there is 1 or 2 of these type of cones, because it's the 3 types, is absent, patient will not be able to identify red, or maybe green, or maybe blue, or red and green. It's more in the male, more than the female, and it is 7% in the male and 0.4% in the female who's suffering from red and the green color blindness. This is how normal people will see the world. It is with blue color, green color, yellow, and this is how person with red, green color deficit sees the world. So see the difference. This patient cannot see the green. And there is another condition called the condition called the achromatopsia. The cerebral achromatopsia. Why it's called cerebral? Because its origin from the cerebral, from the brain. The cerebral achromatopsia is a type of color blindness caused by damage in the cerebral cortex. Mainly, it is in the temporal lobe. So the patient will not be able to see as we see. He will see things as gray. There will not be like red color or green color. Some of the cases recover, but other cases will continue with having this chromatopsia. So we need to understand that this patient, why he's having color blindness. Is it that he has eye problem, or it is because brain problem? Some patients, they don't know the color because they have severe cognitive impairment. So it could be visual from the eye, visual from the brain, and could be also something related to the cognition as well. How the assessment can be done? There is several ways of the assessment. One of them is using the Ishihara test. The Ishihara test, the patient will be presented with colors like the one you see on the screen, like this one. Patient will be presented with cards, and this card consists of numbers, and patient will be asked what number you can see. And also with this one, it will come with instruction catalog. It will tell you if the patient, for example, read this number, which is 25, if he read it, for example, 33, what could be that this patient is having problem maybe with red, he's not able to identify the red color. So he has color blindness in the red color, for example. And this is like a bit complicated way to assess the patient, because some patients, they don't know how to read the numbers. And this is a sample, but you should not rely on this sample because it is in the computer. Some people might see it as 5, and some people will see it as 2. So a normal person will see it as 5, which is revealed among the dots, and a red green color blind person will see it as 2. But don't rely on this because this is on the screen, not in the actual assessment. Simple way of knowing if the patient has a problem with the colors, by asking the patient. We'll give him crayons and we'll ask the patient, now I need you to identify for me the green color. All the green color, pick them. All the blue colors, pick them. Red. And this is very simple way. Or you can tell the child, you give him cubes and you tell him, okay, now give me the green cubes. Or you can show him that you are putting the green together and ask him to continue the task. So many ways to do the activity. You don't have to go to the Ishihara, something very simple. In color perception, we need to educate the affected person and his or her family about the problem. Also to train him on adaptation technique. If somebody is not able at all to identify the colors because of the visual problem, especially from the eye, we need to train them how to identify their clothes, maybe by labeling the clothes, identify objects from shapes, not from their colors. Also, there is something, if you would like to search about it, called the chromogenic glasses. This is a new innovation which is used for the patient with color blindness. It is a glasses, especially glasses, that allow the patient with color blindness to be able to see the colors again, because it's control the waves which go into the eye. So chromogenic glasses is a solution for the color blindness. Another important aspect in the assessment of vision assessment is the contrast assessment. And in contrast assessment, it is it's your ability to differentiate between two colors. If you have two colors near to each other, so how you can identify between these two colors. This is called the contrast sensitivity assessment. There is assessment used, which is called the SNAP test. I can share with you the idea, but it's not necessary that you're going to do the same way of the assessment. You can search for other test. Sorry, let me just get the assessment for you.